So guys, moving on to the development of the arteries in the arterial system. Once again, we need to know that what are the raw material we have using which we can discuss the development of the arterial system. So what we have in the beginning is that during the development of all those mesoderm into three part, paraaxial, intermediate, lateral plate. So just below the paraaxial mesoderm, you will also see the development of two dorsal aorta. Now we have two dorsal aorta with us. The body is having a two aorta developing called as dorsal aorta, one right dorsal aorta, left dorsal aorta. And this is dorsally placed. And we know that with the craniocaudal folding, the heart actually came relatively in front. So imagine if the developing heart tube is in front and we have two dorsal aorta behind. What is the point of having the dorsal aorta if it is not connected to the heart? So the heart will be connected to these dorsal aorta. The developing heart tube will connect it to the dorsal aorta by the pharyngeal arch arteries. How many pharyngeal arches we have in the beginning? That is 6 pharyngeal arch. And every pharyngeal arch is having one artery inside. So then pharyngeal arch artery is actually from this heart tube, it goes backwards and laterally and goes into what? The dorsal aorta. So in the arterial system development, in the development of the arterial system, what you will see that we have the two dorsal aorta. We got a right and the left dorsal aorta. Once again, I'm using these dotted lines here. This is a right dorsal aorta here. And then we have this left dorsal aorta. That is right dorsal aorta and that is left dorsal aorta. I'm writing in short, that is right dorsal aorta, left dorsal aorta. And if you look at the cranial end of the heart tube, what was the cranial end of the heart tube? That was truncus arteriosus. So let me start from there. If this is a truncus arteriosus, if this here is a truncus arteriosus, we have this development of aortic sac, the cranial part of the truncus arteriosus. I'm writing in short only. This is truncus arteriosus and this is aortic sac. Just keep writing these full forms somewhere else separately, not in the diagram. So TA is truncus arteriosus, sinus venosus, primitive atrium, primitive ventricle, bulbus cordis. And then the cranial part of bulbus cordis was this truncus arteriosus. And this is aortic sac. As the name suggests, it is aortic sac. And this aortic sac will have two horns. We have the right horn of the aortic sac and there will be the left horn of the aortic sac. That is a right horn and that is a left horn of the aortic sac. And as we said, these horns of the aortic sac, or this is a part of the heart tube, which will get connected to the dorsal aorta by 6 pharyngeal arch arteries. So this is the first arch artery here. Second arch artery, third arch artery, fourth, let's say fifth, and I'm drawing this one as a sixth arch artery. That is first arch artery, second, third, fourth, fifth and the sixth. Right, so this is what we have with us. This is a raw material using which we have to discuss the development of all major arteries here. So just take 20 seconds and just complete this diagram. Just draw all these dotted lines so that you are with me on the same page. So truncus arteriosus having this aortic sac dividing into the right and the left horn, and then from these left horn we have this 6 pharyngeal arch arteries which are running through the pharyngeal arch and going backwards and draining into the dorsal aorta, connected to the right and left dorsal aorta. Just like inferior vena cava development, once you find out the inferior vena cava, the rest of the tributaries becomes understandable. Same thing here. You need to find out the arch of aorta, that is a main artery, and rest everything is a branch from the arch of aorta itself. So guys, arch of aorta is derived from what structure? So arch of aorta is derived from number one, that is the aortic sac. If I keep knowing, that is aortic sac. Number two, that is the left horn of aortic sac. Number 3, left fourth arch artery. And number 4, left dorsal aorta. Just make sure you highlight that part, and in the meantime I'll write it for you as well on the side. So you're looking at the arch of aorta. Arch of aorta derived from, number 1, from the aortic sac. Number 2, from the left horn of aortic sac. Number 3, left fourth arch artery. And number 4, left dorsal aorta. This is the main thing. Once you find out the arch of aorta, rest is easy. So aortic sac, left horn of aortic sac, left fourth arch artery, and left dorsal aorta, the 4 components which together gives rise to the arch of aorta. Once you find the arch of aorta, I hope you wrote that as well. Once you find out this arch of aorta, guys, then we have 3 branches coming from arch of aorta, the 3 main branches. That is left subclavian, left common carotid, and obviously brachiocephalic artery. Well, this here is the left 7th cervical intersegmental artery. 7th cervical intersegmental artery. The dorsal aorta is giving off many segmental arteries, like we have 7th cervical intersegmental, then thoracic segmental, lumbar segmental artery. So out of those segmental artery, the 7th cervical intersegmental artery, it actually becomes what? Subclavian artery, and that is only toward the left side. Left 7th cervical intersegmental artery is the one which will give rise to the left subclavian artery. It will give rise to the left subclavian artery. We say left subclavian artery is a branch of the arch of aorta. It is, but technically speaking, if you'll see it from the developmental point of view, it is a branch coming from the dorsal aorta, from the left dorsal aorta directly. But that piece of dorsal aorta is utilized to form the arch of aorta. So that is why the left subclavian artery looks like coming from the arch of aorta itself. So 7th cervical intersegmental artery, it gives rise to the left subclavian. We do have 7th cervical intersegmental on the right side as well, but that is a completely different scenario there. So what you'll see here, one artery is 7th subclavian artery, left subclavian. The second major artery coming from arch of aorta is the common carotid. So we have the left common carotid artery. Now common carotid artery, guys, look at this. It comes from this third arch artery. If I highlight this part, this is a third arch artery and this cranial part of the dorsal aorta. This cranial part of dorsal aorta. If you remember that concept of vasculogenesis and angiogenesis, when you see the blood vessels in continuation, common carotid artery, it continues as internal carotid artery, isn't it? So this is giving rise to common carotid artery as well as internal carotid. Whereas the bud for external carotid artery will emerge from the third arch artery. This is the common carotid artery. This is internal carotid artery, the rest of it. And this is the bud coming out, that is the bud of external carotid artery. Let me just enlarge this thing for you. So we got a common carotid artery, we got the bud for external carotid, and this rest of it is the internal carotid artery. So if for the writing purpose, common carotid artery, what you'll say, where the common carotid artery is derived from? It is derived from which arch artery? Third arch artery. But not entirely. From the proximal part of third arch artery. Common carotid is by the proximal part of third arch artery. Internal carotid is by the distal part of third arch artery as well as this cranial part of dorsal aorta. Once again, it's better to write it down. We said common carotid artery, it is derived from what? It is derived from the proximal part of third arch artery. Proximal part of the third arch artery. See, I'm not writing right or left because we have the same component on the right side as well. So you have to say, because we are talking about the branch of the arch of aorta, so I should say left common carotid artery and left third arch artery. But because we have exact same component toward the right and left side, so just to so that there won't be more any confusion in that, I'm not using the word right and left here. Proximal part of third arch artery on both sides will give rise to common carotid. Whereas the internal carotid artery is the one which comes from where? It comes from the, first of all, from the distal part of third arch artery, and also by the cranial part of dorsal aorta. Also by the cranial part of dorsal aorta. That is the internal carotid artery, which is derived from the cranial part of the dorsal aorta along with distal part of third arch artery. So these are the two direct branches coming from the arch of aorta. One is the subclavian artery, and now you saw that common carotid artery, left common carotid artery. What is the third main artery from the arch of aorta, guys? That is the brachiocephalic. Now we know that brachiocephalic artery purpose is to go toward the right side and again divide into the common carotid and subclavian. So the brachiocephalic artery is just by this. And what is that? That is the right horn of aortic sac. That's it. Please write that. That brachiocephalic artery is by the right horn of aortic sac. Brachiocephalic artery will be derived from this right horn of aortic sac, the right horn of aortic sac. Right horn of aortic sac. And once you find out this right horn of aortic sac giving rise to brachiocephalic artery, the common carotid artery and subclavian artery are the branches coming from this brachiocephalic. Common carotid, no problem. It's just like on the left side. There we go. Same again. Third arch artery. And then cranial part of dorsal aorta. And this is the bud for external carotid. So it's all same. I just need to write common carotid artery here. It makes sense. The rest is internal carotid and external carotid. The main challenge here is the subclavian artery. Now subclavian artery on the left side, we can see on the left side it is coming from the left 7th cervical intersegmental artery only. But that is not possible on this side. Look at this, guys. If this is the right 7th cervical intersegmental artery, let me put that first. This is the right 7th cervical intersegmental artery. But this right 7th cervical intersegmental artery alone cannot form the subclavian artery. Subclavian artery on the left side, it comes from the brachiocephalic artery. And brachiocephalic artery is here. This is the brachiocephalic artery. So we need the connection of this brachiocephalic artery to this 7th cervical intersegmental. How is it done? Now on the left side, we have 4th arch artery forming arch of aorta. On the right side, there is no arch of aorta, but obviously we have the 4th arch artery here. So this time I can use this 4th arch artery, that is number 1, the 4th arch artery. I can use this dorsal aorta, that is this number 2, and then the 7th cervical intersegmental artery. So basically there are 3 components for the development of the right subclavian artery, the 3 components which I'm marking here. What is number 1? That is a right 4th arch artery. What is number 2? Right dorsal aorta. And what is number 3? That is right 7th cervical intersegmental artery. So all these 3 together will give rise to the right subclavian artery. This 1 plus 2 plus 3, they together will give rise to the right subclavian artery. If you could just repeat what is 1, 2 and 3 and make sure to write it also. 1 is the right 4th arch artery. Number 2 is what? That is a right dorsal aorta. And number 3 is the right 7th cervical intersegmental artery. Right 7th cervical intersegmental artery. So these are the 3 components of the right subclavian artery. It's so much different from the left side. Left side only 1 artery, and right side we have the 3 arteries together which is forming the subclavian. Okay. This is about the arch of aorta and the branches from arch of aorta. Now, guys, let us say here we have the developing lung buds or the respiratory buds. Remember the respiratory buds we talked about developing from the foregut. So let us say these are the lung buds or the respiratory buds, those endodermal buds. And these lung buds are invaded by this developing 6th arch artery. Look at that. The lung buds which are invaded by this developing sixth arch artery. So obviously what are we talking about? We're talking about the pulmonary artery here. That is pulmonary artery. So how does the pulmonary artery comes into the picture? Pulmonary artery is derived from what? Well, sixth arch, not the entire sixth arch, that is the proximal part of sixth arch artery. That is by the proximal part of the sixth arch artery. Fifth arch completely disappears. So there is nothing about the fifth arch to be discussed. So proximal part of sixth arch artery, this will give rise to the pulmonary artery. And if this is pulmonary artery, that also explains me about this. What is that, guys? What is this? This is nothing but the ductus arteriosus. Look at that. That is ductus arteriosus, connecting the pulmonary artery to the arch of aorta. That is ductus arteriosus. So what you will say, ductus arteriosus is derived from where? Let me write that as well. Ductus arteriosus is derived from the distal part of the left sixth arch artery. Distal part of the left sixth arch artery. The distal part of the left sixth arch artery. This is the one which will give rise to the ductus arteriosus. Ductus venosus was the one which was in the liver. Remember? Left umbilical vein shunting the blood toward the hepatocardiac channel. This is the ductus arteriosus, which is by the distal part of left sixth arch artery. So guys, this is about the development of all the major arteries coming from the arch of aorta and the two branches from the pulmonary trunk as well. That is the pulmonary arteries. If I may ask you to just go back into your notes in the pharyngeal arch column, guys. Can you just give yourself a minute and go back into the pharyngeal arch embryology we discussed, where we drew all those tables. In the first column, we write the arch and the nerve of the arch, the muscle and the cartilage, and the last column was about artery. So can you just go back there and just look at that page? Now, if you've reached there, if you're looking at that table, now look at what is the artery we wrote for the first arch, guys. The artery from the first arch, we wrote the maxillary artery. So maxillary artery actually is the remnant of this first arch artery. Look at this first arch artery here. We didn't draw anything in this. So the remnant of the first arch artery is maxillary artery. Although we know maxillary artery is a branch of external carotid, and external carotid is developing from third arch. They develop separately. Maxillary artery separately, external carotid separately. Later on, external carotid will join with the maxillary. So maxillary artery is a remnant of the first arch artery. What is the artery you wrote for the second arch? You wrote it the stapedial artery and hyoid artery. Again, that is a remnant of the second arch artery, forming the stapedial artery and the hyoid artery. What is the artery you wrote for the third arch? Now, this is the portion from where it makes more sense. Third arch artery, you wrote common carotid and internal carotid. Look at this, makes sense? Common carotid, and then continuation is forming what? Internal carotid. That is from third arch. Fourth arch artery, we wrote what? Arch of aorta. Look at this fourth arch is forming arch of aorta, and also the right subclavian artery. So arch of aorta and the right subclavian. And sixth arch artery you've written is the pulmonary artery and the ductus arteriosus. This pulmonary artery and ductus arteriosus is the sixth arch artery. That's the reason we wrote those arteries there, because whatever arteries we have in those pharyngeal arches, ultimately they will give rise to these adult arteries, that is maxillary or stapedial or common carotid, arch of aorta or pulmonary artery. So well, this is about the development of the normal arterial system. There is more to it, guys. I mean, there's this recently a question, like 2 years back, there was a question asked in the AIIMS exam about the formation of the abnormal subclavian artery, abnormal right subclavian artery. So let me tell you about the abnormal right subclavian artery. But before that, to understand that better, you should know that the right dorsal aorta and the left dorsal aorta, we have the right and left dorsal aorta separate, but in the lower part of the body, the right and left dorsal aorta, they fuse also and form a fused dorsal aorta. They form a common aorta then, when they fuse in the lower part. What I'm saying, let me put it diagrammatically. This is the right dorsal aorta. And this here is a left dorsal aorta. And you can see they're fusing in the lower part. This is the right dorsal and that is left dorsal aorta. What we already know from the development of arch of aorta. So just let me draw this arch of aorta here. This is the usual arch of aorta. And here is the brachiocephalic trunk. Let me just put these two first. Arch of aorta and that is brachiocephalic trunk. We already discussed that. Now let me put this demarcating line to the arch of aorta, guys. If till this point it is arch of aorta, below the arch of aorta, obviously that will be the descending aorta. So this picture gives me an idea about the descending aorta, thoracic as well as abdominal. This descending aorta will be derived from what? The descending aorta will be derived from the, number one is this and number two is this. That is the caudal part. There is a caudal part of the left dorsal aorta. Caudal part of left dorsal aorta. And also by the fused dorsal aortae of both sides. Fused dorsal aorta, right and left aorta fusing. They together will give rise to the descending aorta. So after arch of aorta, this is the descending aorta, which is derived from the caudal part of left dorsal aorta and the fused dorsal aorta. I'm moving toward my question. Now, from the brachiocephalic artery, we know that subclavian artery will also come. And if I just point, don't draw it entirely, subclavian artery was by what? That was by this fourth arch artery. That was by the fourth arch artery, the dorsal aorta, and then by this seventh cervical intersegmental artery. Right? This was the normal right subclavian artery. But the question asked was about the abnormal right subclavian artery. What is abnormal right subclavian artery? If there is obliteration of this fourth arch artery, imagine this fourth arch artery obliterates on the right side. If the fourth arch artery will obliterate on the right side, that means the subclavian artery now cannot come from brachiocephalic. So where the subclavian artery will come from? Well, the only option left is this. The subclavian artery will come from this caudal part of the right dorsal aorta and the seventh cervical intersegmental artery. Make sense? This is the persistence of caudal part of right dorsal aorta. And this, though, obviously we know that is the right seventh cervical intersegmental artery. These two together will give rise to the abnormal. These two together will give rise to the abnormal right subclavian artery. That will give rise to the abnormal right subclavian artery. So these are the two components the question is asked. It's the persistence of the caudal part of right dorsal aorta which gives rise to the abnormal right subclavian artery. And the abnormality here, the anomaly here, the problem here is it is a right subclavian artery we are talking about, imagine, and it is now coming from where? From the aorta. Aorta is on what side? Aorta is on the left side. And artery we are talking about is right subclavian artery. So if right subclavian artery comes all the way from the aorta, that is from the left side to right side it will come. So it will also cross the esophagus and can compress the esophagus and causing dysphagia lusoria also. If let's say this is esophagus, that is esophagus. So esophagus is being crossed by this artery here. It can cause dyspnea as well, but it is more closely related to esophagus, so causing the dysphagia lusoria. That can cause a dysphagia lusoria. This is about the abnormal right subclavian artery, which is formed by the right seventh cervical intersegmental and also by the caudal part of right dorsal aorta if it persists. Both these will form the abnormal subclavian artery, right subclavian artery, and that can cause dysphagia lusoria. And I want you to take your attention to one very important thing here, guys. Please understand that I have said that there is an obliteration of that fourth arch artery. This is also very important to note. That is obliteration of the fourth arch artery there, and then the persistence of the dorsal aorta. Just for 1 second, imagine we have a persistence of the fourth, dorsal aorta on this side, that is there. But there is a persistence of fourth arch artery also. If both will persist, in that case we have both fourth arch arteries and we have both caudal part of dorsal aorta. And that will give rise to the double aortic arch. That will give rise to a double aortic arch. You can note that also, that persistence of both side fourth arch artery and persistence of caudal part of both dorsal aorta will give rise to the double aortic arch. I'll repeat again this for you if you're writing. Persistence of both fourth arch artery, right and left both, persistence of both fourth arch artery and caudal part of both dorsal aorta. And caudal part of both dorsal aorta gives rise to the double aortic arch or double arch of aorta, you can say. It is forming a vascular ring around the trachea and the esophagus and compress the trachea and esophagus as well in between. That is also called as a vascular ring. Double aortic arch or vascular ring around the ascending aorta and pulmonary trunk. Ascending aorta and trachea, vascular ring around the trachea and esophagus. So this is about the arterial system development. I hope you understood the part of how the main arteries are coming into the picture, and especially this question, which was an image-based question in AIIMS about the development of abnormal right subclavian artery. I just once again warn you on this question. The question is not complete, the answer is not complete if you just say the persistence of the caudal part of right dorsal aorta. You also have to say obliteration of the fourth arch artery. Then only you will say that abnormal subclavian artery is coming from the descending aorta. So both statements are important here. So this is about the development of the vascular system, guys. We talked about the major veins and the arteries. And in the third and the last part, we'll be talking about the interatrial, interventricular septum, and as well as the development of diaphragm in that part. Now, starting with the interatrial septum. First, the interatrial septum. Nothing much in that. So, skipping the steps, and I'm going to the main thing here. If this is the right atrium, and let's say this is the left atrium here, if you're seeing it from the front. So what you see, interatrial septum is mainly by the two septums. One is called as septum primum and one is septum secundum. Septum primum starts from above only, but once it goes and fused with the endocardial cushion in the lower part, the upper part of the septum gets perforated. So the final picture would be something like this, that the interatrial septum is by septum primum, which will later on will be seen in the lower part, and above we have the space. And there is a septum coming from the roof of the right atrium. Look at this, it comes from the roof of the right atrium. That is called as septum secundum, which is kind of overlapping the septum primum. If this is the future's right atrium and here is the left atrium, the two septum, here one is the septum primum. That is septum primum. And this septum which is present above here, that is the septum secundum. Septum primum and septum secundum. The primum comes first, the secundum comes second. So primum and secundum. So interatrial septum is formed by the septum primum and secundum, and this oblique passage of the blood, this shunting of the blood from the right atrium to the left atrium through this slit-like passage in between, that is obviously the foramen ovale. There is a foramen ovale which persists between the septum primum and secundum. But once the lungs get functional and there is an increased blood flow into the left atrium from the pulmonary veins, then obviously this foramen ovale will get obliterated, and then it will become fossa ovalis. Now let's understand how exactly fossa ovalis will be formed. First of all, septum, primum and secundum, we say they form the interatrial septum. But when you look at the fossa ovalis is having a floor of fossa ovalis and the limbus. We talked about this in the gross anatomy also. So this limbus of fossa ovalis, or you can say the margin of fossa ovalis, is derived from septum secundum. It is coming from above, and that forms the margin of the fossa ovalis. And this here is the floor of fossa ovalis. Floor of fossa ovalis is the one which is derived from the septum primum. So if the floor or limbus, anything is not mentioned, if the question is asked that fossa ovalis is derived from where, you obviously have to go with the septum primum. Septum primum is the one which forms a depression. That fossa is by the septum primum, and the margin of that fossa or the limbus of that fossa is by the septum secundum. This is about the interatrial septum. The one which is more important and one which the questions are more frequently asked, that is interventricular septum. That is interventricular septum. For the interventricular septum, we have three components. Now let me write those components, guys. Number one, interventricular septum is contributed first of all is by the endocardial cushions. Endocardial cushions will form the membranous part of interventricular septum. That will form the membranous part of interventricular septum. Membranous part. Then myocardium. That is cardiac muscles itself. Cardiac muscle themselves is forming a major chunk of the interventricular septum. That forms the so-called muscular part of interventricular septum. That forms the muscular part of interventricular septum. And number three, that is the neural crest cells. Well, neural crest cells will also give rise to a part of the interventricular septum called as the bulbar septum. Bulbar septum is that part which divides the infundibulum of the ventricle. So it divides the infundibular part, that outflowing part of the ventricle is divided by this bulbar septum. So we have three things with us: membranous part, muscular part, and then the bulbar septum, which is derived from neural crest cells and divides the infundibulum of the ventricle. If I put it schematically, guys, let us say this here is the ventricle, and let's say the ventricle is till only here. Let's not go beyond this line. This is the ventricle, the one below, and this above is the truncus arteriosus. Even truncus arteriosus need to divide into ascending aorta and pulmonary trunk. So this is the truncus arteriosus, and below we got the ventricle. Interventricular septum, we said endocardial cushion will form the membranous part of interventricular septum. That is a membranous part. Let me go with these numbers. That is membranous part of interventricular septum. We gave it number 1, that is membranous part. Second major part of interventricular septum is by the cardiac muscles only. This is the major part, that is number 2. Muscular part of interventricular septum, which is found by the cardiac muscles. And number 3, which is very, very important, derived from the neural crest cells. Derived from the neural crest cells. This is the bulbar septum. Let me write that once again. This is the bulbar septum, and this is the derivative of the neural crest cell. I'm writing it for the purpose separately. Bulbar septum derived from neural crest cells. When the question is about the development of interventricular septum, these are the three. We have membranous part, muscular part, that is the largest one, and then we have the bulbar septum dividing the outflowing part of ventricle, that is the infundibulum of the ventricle, which is leading into the pulmonary trunk and ascending aorta. But guys, we have to divide the ascending aorta and pulmonary trunk also. We have truncus arteriosus, which obviously will give rise to the aorta and pulmonary trunk, but how? There is a septum developing between the two as well. Not the part of interventricular septum, but this is a septum which also have some importance here. the septum which divides the truncus arteriosus in two parts. One will form the ascending aorta and other will form the pulmonary trunk. One half will form the ascending aorta and other half form the pulmonary trunk. Let's just say this is going to be the ascending aorta part and this one is going to be the pulmonary trunk. So what should be the name of this septum? This septum is called as the aortico-pulmonary septum. We call it aortico-pulmonary septum. It is dividing the ascending aorta, future ascending aorta and the pulmonary trunk. Or it is also called as the spiral septum. The catch is, this is also derived from where? From the neural crest cells. This is very, very important, that bulbar septum is derived from the neural crest cells, which is dividing the ventricle. Truncus arteriosus is divided by the septum called as the aortico-pulmonary septum or spiral septum, which is also derived from neural crest cells. That means if there is any anomaly of the bulbar septum, or if say any anomaly of spiral septum, there are chances of the anomalous part of the other septum also. One of the reasons why in case of the anomalies of the truncus arteriosus, we usually have the ventricular septal defect also. Because the septum of the ventricle and the septum of the truncus arteriosus, they both are coming from the same source, and that's neural crest cells. So anomaly of one, there are very good chances there could be anomaly of other part as well. Now first of all, why do we call it spiral septum, guys? I mean, aortico-pulmonary septum, it makes sense. Aortico-pulmonary septum, dividing ascending aorta and pulmonary trunk. Why do we call it the spiral septum? Because of its spiral growth. Now look at this animated video and this will give you an idea about that, the reason for calling it the spiral septum. So guys, let us understand in this picture how the spiral septum is called as spiral septum. Now the septum will divide this ascending aorta and the pulmonary trunk. And the reason we call it the spiral septum, because look at this, it is not going straight. It is kind of twisting and then coming downward and meeting with this interventricular septum. And the purpose is, the reason it goes in a twisted manner, so that the blood now from this left ventricle can go behind the spiral septum into the ascending aorta, which is there on that side. And the blood from the right ventricle can come in front of the spiral septum and can go into the pulmonary trunk. And that is why we call it the spiral septum, because it grows spirally, not the straight. If it goes straight, that will be the condition of transposition of great arteries. Now I hope you understood that the reason for calling it the spiral septum. Now coming to this one last thing, that the anomalies of the spiral septum. What could be the anomalies of the spiral septum or so-called aortico-pulmonary septum? So for that, let me take this truncus arteriosus. If this is the truncus arteriosus, and we said truncus arteriosus is divided by the septum. What is that septum? That is the spiral septum into what? Into the ascending aorta and pulmonary trunk. So let us say this is ascending aorta here, and here is the pulmonary trunk. There is ascending aorta and pulmonary trunk divided by the spiral septum. So three conditions here, guys. There are three conditions. Condition number one, that there is if there is anterior displacement of the spiral septum. Let's say there is this anterior displacement of the spiral septum. Now you see this ascending aorta and the pulmonary trunk. Well, if there is anterior displacement of spiral septum, you can clearly see that aorta is increasing in size and there is pulmonary stenosis. Overriding of aorta, pulmonary stenosis, right ventricular hypertrophy, that will lead to what? Tetralogy of the fallet. So the anterior displacement of the spiral septum, I tried SS, will lead to the fallet's tetralogy, the tetralogy of the fallet. Condition number two, if there is non-spiral course of spiral septum, it goes straight. As I said, instead of going in twisted manner, it goes straight. So we call it non-spiral course of spiral septum. So then there is a case of the transposition of great arteries. Ascending aorta will come from the right side and pulmonary trunk from the left side. So if there is a non-spiral course non-spiral course of spiral septum, that will lead to the transposition of great arteries, the TGA, transposition of great arteries. And condition number 3, if there is absent spiral septum, if it completely it's absent, so nothing is dividing this ascending aorta and the pulmonary trunk, there is a mixing of the arterial and the venous blood, and there is a cyanosis also. So there is absent spiral septum will give rise to the persistent truncus arteriosus, that is PTA, persistent truncus arteriosus. The persistent truncus arteriosus, that is by the absent spiral septum. So remember these 3 important anomalies: tetralogy of Fallot, anterior displacement of the spiral septum. Straight spiral septum, that is non-spiral course, lead to the transposition of great arteries. And then we have the absent spiral septum, that will give rise to the persistent or patent truncus arteriosus. This is about the truncus arteriosus and its anomalies. And guys, very lastly in this embryology part, let us also talk about one, although it's very, very important, and we are discussing it at the end, that is the development of the diaphragm. Development of the diaphragm. In the diaphragm development, first of all, once again, there are 4 things which are required for the diaphragm development. Number 1, which you already know, is the septum transversum. And septum transversum was giving rise to the central tendon of the diaphragm. It forms the central tendon of the diaphragm. Number 2, that is called as the cervical myotome. Well, myotome come from somites, so either you call it cervical myotome, or you can simply use the word that is body wall mesoderm. Simple and straight, body wall mesoderm or cervical myotome. Phrenic nerve supplies the diaphragm, so obviously which somites or which myotome, that is cervical myotome. And these cervical myotome will form the muscular part of the diaphragm. That will form the muscular part. Number 3, that is the dorsal mesentery of esophagus. Dorsal mesentery of esophagus, the mesentery of the esophagus is absorbed to give rise to the crus of the diaphragm. The right and the left crus of diaphragm are by the absorption of the mesentery of the esophagus, right and left crus of the diaphragm. And number 4, that is a pleuroperitoneal membrane. Now this is important part, guys. Pleuroperitoneal membrane. This will be proliferated by the muscle tissue only. But what is this pleuroperitoneal membrane and all? Now initially when you say pleura and peritoneal cavity, there's a single cavity only. This is, let's say, pleural cavity, there is a peritoneal cavity. And with the development of the diaphragm, the pleura and peritoneal cavity, they start separating from each other. So let us say when the diaphragm starts developing from both the sides, so this would be something like in this way. So we have the pleura and the peritoneum getting separated from each other. And once they are completely separated from each other by the formation of this, still there is a membrane. I mean, there's a membrane over there in between. This membrane is called as a pleuroperitoneal membrane. Now you can see the pleural cavity and peritoneal cavity separate completely. This membrane is pleuroperitoneal membrane. This canal here, which was there, I mean, while development, this canal is called as the pleuroperitoneal canal. This is called as pleuroperitoneal canal. Now, there are 2 important conditions that you should remember. If the pleuroperitoneal canal should convert into pleuroperitoneal membrane, the membrane should form. But if the pleuroperitoneal canal, it persists, if pleuroperitoneal canal persists, or you can say if there is an absence of pleuroperitoneal membrane, same thing, persistence of pleuroperitoneal canal means the absence of pleuroperitoneal membrane, and that will give rise to the congenital diaphragmatic hernia, which is more common toward the left side, the Bogdalex hernia or the congenital diaphragmatic hernia. The Bogdalex hernia or congenital diaphragmatic hernia is because of the persistence of pleuroperitoneal canal. But there is one more condition. Let us say pleuroperitoneal membrane is formed. It is done, right? Now we have pleural and the peritoneal cavity, the two separate cavity. But still there is failure of proliferation. If there is a failure of proliferation of the cells inside the pleuroperitoneal membrane, the muscle tissue will not come inside and you will just have a thin membrane separating the pleura and the peritoneum. So this failure of proliferation of the pleuroperitoneal membrane will give rise to the evertration of the diaphragm. That is called as the evertration of the diaphragm. The everted diaphragm, you will see evertration of the diaphragm. Membrane is there separating the abdominal cavity and this thoracic cavity, but that membrane is not good enough, it's not strong enough because there is no muscle tissue inside to stop the abdominal content to herniate into the thoracic cavity here. So that is called as the evertration of the diaphragm. The membrane is separating them. It's not a true congenital diaphragmatic hernia, but yes, there is still protrusion of the colon and all into the thoracic cavity because of this very, very thin membrane, which is because of the failure of proliferation of cells inside the pleuroperitoneal membrane. Recently, they also asked an image-based question on this part. And what that image-based question was, they gave all these four components and the question was that congenital diaphragmatic hernia is because of the maldevelopment of which of the following. So even if you know that pleuroperitoneal membrane is giving rise to the absence of pleuroperitoneal membrane gives rise to the congenital diaphragmatic hernia, you should be able to identify the membrane also in the image. So it's not difficult. It's a very simple picture in the developing diaphragm. See how the things will look like. So the most anteriorly placed, this will be septum transversum, which forms the central tendon. Folding brings the septum transversum here. So this is septum transversum, which is right now in the front. That is the septum transversum. Number two, that will be the dorsal mesentery of esophagus, which will be seen more in the midline like this. That is a dorsal mesentery of esophagus. This is a dorsal mesentery of esophagus. That is dorsal mesentery of esophagus, which is giving rise to the crus of the diaphragm. The one that you see more posterior laterally placed, this is the body wall mesoderm, or you can say cervical myotome, which is giving rise to the muscle part. That is the body wall mesoderm, more posterior laterally placed. And guys, in between, this is the pleuroperitoneal membrane. Even if you remember this schematic line diagram, this you can still able to answer that question. The question was that congenital diaphragmatic hernia is because of the maldevelopment of which of the following structure, and the answer is the pleuroperitoneal membrane, which is residing somewhere in between all other components here. That is a pleuroperitoneal membrane. So this is about the development of the diaphragm and the anomaly related to it. And with that, we conclude the embryology part. I hope you understood, you got a good concept of the embryology by now, and this portion is going to help us immensely in the other units also, like whether it's the thorax part or whether it's abdominal part, and in understanding so many anomalies that you read in medicine and surgery as well. So guys, let's start with the midgut development. Well, out of the foregut, midgut and hindgut, I can very confidently say that midgut is definitely the most important part, because all the rotations and rotational anomalies, they are the potential questions to be asked in the exam, and some of the potential image-based questions also. So in the midgut thing, as we know that extension of the midgut is from the duodenum, from the major duodenal papilla to the junction between the right 2/3 and left 1/3 of transverse colon. So if you compare the foregut, midgut and hindgut, the size of the midgut is huge. I mean, midgut has to form the small intestine, it has to form the jejunum, ileum, and it has to form the major chunk of large intestine also, the ascending colon, cecum and appendix. It also have to form this right 2/3 of transverse colon. So what I'm showing you is a picture of the 6th week. Now in the 6th week, abdominal cavity is small in size and liver is relatively large, I mean, compared to other organs. So we have a very small midline, this abdominal cavity, and imagine the rate of growth of midgut is so fast that it is not going to stay inside the this abdominal cavity. So what midgut loop will do, it will herniate out of the umbilical opening. So guys, if this is the midgut loop, here we go, this is a midgut loop here. What we already know, that what is the artery for the midgut? That access artery of the midgut is the superior mesenteric artery. So you're looking at a midgut loop that is supplied by the superior mesenteric artery. And based on the axis of this artery, based on the axis of superior mesenteric artery, we can divide the midgut loop in 2 parts. This part of the midgut, which I'm highlighting here, it is after the axis of the superior mesenteric, and therefore we call it what? Post-arterial segment, and the one above is pre-arterial segment. Let me write that. That is a pre-arterial segment. That is a pre-arterial segment, which mainly will give rise to the small intestine in future. And this here is the post-arterial segment. That is the post-arterial segment, which mainly gives rise to the large intestine. Whatever large intestine is to be formed by the midgut, that is by the post-arterial segment. And if pre-arterial segment forms the small intestine and post forms the large intestine, so obviously we can say that cecal bud and appendicular bud will also come from where? From the post-arterial segment only. The cecal bud and appendicular bud will also extend from the post-arterial segment. Now we said in the 6th week, abdominal cavity size is very small, and the pace of the growth of this midgut loop is very, very fast. So that's why this midgut loop is not going to stay inside the abdominal cavity. This midgut loop will herniate. It comes out of the umbilical opening. It comes out of the umbilical opening. This comes out of the umbilical opening, and this is called as a physiological umbilical hernia. This is called as the physiological umbilical hernia. It's a normal physiological hernia because it's not pathological. This hernia has to reduce, so we call it physiological hernia. So this is a scenario. We have 6th week, herniation is taking place, pre-arterial segment is above, post-arterial segment is below, and then you can see the cecal and appendicular bud is also coming from the post-arterial segment itself, coming out of this umbilical opening. So what exactly will happen, how the rotation will take place, how this pre-arterial segment and post-arterial segment with respect to each other will keep on changing their position, the moment it would come back into the abdominal cavity, what is the placement of that, let us discuss all that. So I'm going to perform some movements in front of you with using my both arm and forearm, and then let's understand that how exactly the rotation actually took place and what will be the final placement of the intestine. Once we are done with that part, we will also talk about some malrotations, non-rotation, reverse rotation, all those things as well. So look at this next section in which I'm trying to explain you how exactly the rotation takes place and what is the positioning of the intestine. So guys, as communicated to you, the pre and the post-arterial segment. Now let us say this is the pre-arterial segment. That is let's say my right arm and forearm is forming the pre-arterial segment here. And this is a post-arterial segment which is formed by my left arm. And imagine all the rotation on me. So please understand 2 things, that if you're looking at a rotation like this, you need to consider the clockwise and anti-clockwise rotation from your side. I mean, when you'll say clockwise or anti-clockwise, you have to see from that your side, your end. But when you talk about the placement of intestine, whether the small intestine goes toward the right side or large intestine to whatever side, you got to talk about it from my aspect. So if I say that herniation takes place, pre-arterial segment is above and post-arterial segment is below. That is how it started. And we have a superior mesenteric artery in between, which is acting like an axis. So first 90-degree anti-clockwise rotation takes place. Look at this. Anti-clockwise for you guys, right? So the first 90-degree anti-clockwise rotation takes place, resulting in pre-arterial segment coming to my right side and post-arterial segment to my left side. That is, the future small intestine is to the right side and future large intestine is toward the left side. And let's say this here is the cecum and appendix. Let's say my watch here is corresponding to the cecum and appendix. The cecal and appendicular bud is also toward what side right now? That is on the left side. So that's the first step. Herniation took place. First rotation, that is 90-degree anti-clockwise. Pre-arterial segment to the right side. Post-arterial segment to the left side with cecal and appendicular bud. Now, if you compare the pre and post-arterial segment, if I have to compare between these two only, then which will grow faster? Then obviously it is a pre-arterial segment. Pre-arterial segment gives rise to the small intestine. The jejunum and ileum loop will be formed by the pre-arterial segment. So it's quite obvious that the rate of growth of the pre-arterial segment will be much faster. So this pre-arterial segment keep on growing inside the umbilical opening, and when it grows inside the umbilical opening, so much of growth has taken place that when the time for this midgut loop to come back into the abdominal cavity is there, they are kind of stuck inside. They cannot come back like simultaneously. So what will happen? First, pre-arterial segment will come back into the abdominal cavity, and simultaneously second rotation will also take place. Look at this. If this pre-arterial segment, which has already grown a lot, if this pre-arterial segment comes back into the abdominal cavity and the second rotation also takes place, that is also anti-clockwise. The purpose for this second rotation to take place with the reduction of hernia, so that the small intestine which came in, it gets shifted toward what side? Toward the left side. You have to create the space toward the right side for the post-arterial segment to come inside, isn't it? So what happens is pre-arterial segment comes inside and simultaneously there is a rotation as well, which will bring the pre-arterial segment toward what side? Toward the left side. Followed by that, post-arterial segment will also come inside, that is the reduction of the hernia takes place, and simultaneously third rotation is also happening. See it again. Herniation, first rotation, pre-arterial segment to the right side, post-arterial segment to the left side. What comes back first? Pre-arterial segment comes back first and get rotated toward what side? Toward the left side. Post-arterial segment will now follow inside with a third rotation also taking place here. Now once the reduction of hernia takes place, all the three rotation has taken place, the cecum is actually somewhere below the liver. It is subhepatic in position. Liver is not readily going into the iliac fossa. So the liver that we are looking at, the liver goes into the subhepatic position, and then this liver goes into the right iliac fossa, well, not by the rotation, but by the extension of the posterior abdominal wall. There is a differential growth in the posterior abdominal wall, and that will give rise to the elongation of the ascending colon is formed, and the cecum will reach into the right iliac fossa. What I'm trying to say here, that even after the three normal rotation, the cecum is not directly going into the right iliac fossa. Cecum goes into the right iliac fossa by the formation of ascending colon, and that is done by the differential growth of posterior abdominal wall. And look at this, guys, we have to use the word differential growth because kidneys, which we'll discuss eventually, kidneys will develop from the metanephros into the pelvic region. Cecum is somewhere here. So, and both are on posterior abdominal wall. So cecum has to go down, but kidney has to come up. So the growth is not in one direction. It's a differential growth. Something is going up, something is coming down. So that is the cecum bringing into the iliac fossa. One more time. Herniation, first rotation, pre-arterial to right side, post-arterial to left side. Pre-arterial comes inside first and then rotates toward the left side. And then the post-arterial segment is followed. That also makes pre-arterial segment overlapped by the post-arterial segment. That is right also. Our small intestine is overlapped by the transverse colon. So that is correct. And the cecum, when it comes in, it is not going readily into the iliac fossa. It is somewhere subhepatic in position. And then from that subhepatic position, it goes into the right iliac fossa by the growth of the posterior abdominal wall. So just to recap what we discussed, let us also have a look at this animated video in which you can see the rotation of gut taking place. So what you see, guys, that in the close view, that umbilical opening, you can see that umbilical opening there. The midgut loop will come out of this umbilical opening with pre and post arterial segment. Look at this. Now this pre-arterial segment which is above You can see there's a first rotation taking place and bringing the prearterial segment toward that right side. You can see the cecal and appendicular bud also. Formation of the jejunum and the ileal loop from the prearterial segment, and the same prearterial segment goes back into the abdominal cavity and comes toward what side? Toward the left side. That's the second rotation taking place. And the third rotation will bring the cecum into the abdominal cavity just below the liver or subhepatic in position, and then it goes into the right iliac fossa by the growth of the posterior abdominal wall. So just a animated view of what we discussed, that how the rotation of the gut takes place and what is the normal positioning of the intestine. So guys, let me write down what all steps you saw in this rotation of the gut. So we said the first rotation, as I just performed in front of you, the first rotation, I'm writing first R for the rotation, first rotation, which is 90-degree anti-clockwise. First rotation is 90-degree anti-clockwise, and so are other rotation as well. Site for the first rotation is the umbilical opening. Site for first rotation is umbilical opening, and the ultimate result, once the rotation is done, the ultimate result was that prearterial segment came to the right side and postarterial segment went to the left side. So it's the prearterial segment to right side and the postarterial segment to the left side. This is what you have to remember, the final picture. I mean, the first rotation when it took place, the final picture was that prearterial segment, that is the future small intestine, was toward the right side and large intestine was toward the left side. Second rotation, let me write this R for the rotation, that is second rotation is again considered as 90-degree anti-clockwise. Second rotation is also 90-degree anti-clockwise. And if you remember the site for the second rotation, well, the main chunk of the second rotation takes place in the abdominal cavity only. The main chunk, the rotation was actually during the reduction of hernia, and it was to take the small intestine toward the left side. So second rotation was during the reduction, so that of the hernia. So site is the mainly abdominal cavity, and the final picture is, the result is that prearterial segment is overlapped by post-arterial segment. Prearterial segment is overlapped by the post-arterial segment. That's what we saw, that our small intestine is overlapped by the large intestine. The transverse colon is in front of the duodenum. That makes sense. So that's prearterial segment is overlapped by the post-arterial segment. Whereas a third rotation, which again took place in the abdominal cavity only, 90-degree anti-clockwise, third rotation is 90-degree anti-clockwise. The site is the abdominal cavity. The site is again abdominal cavity, and what this does, that it brings the post-arterial segment inside and cecum goes into subhepatic position. Cecum goes into subhepatic position. That's what happened after the third rotation. That's a thing to be noticed after the third rotation, that the cecum goes into subhepatic position. And then this subhepatic cecum, it goes into the right iliac fossa. It goes into the right iliac fossa. That is by what? By the differential growth of posterior abdominal wall. There is a differential growth of posterior abdominal wall which brings the cecum and appendix into the right iliac fossa. So this is about the normal rotation, as we said. And overall picture, if we see, herniation. What was the week for the herniation? It was in the 6th week. Herniation took place in the 6th week. There's a question also that reduction of hernia will take place in which week? Well guys, the reduction of hernia will take place by 10th week. So herniation occurred in the 6th week, but it's the 10th week when it comes back into the abdominal cavity. That is the 10th week. And overall total rotation that we just counted, total rotation, it is like 90-degree rotation happened anti-clockwise 3 times. So that is a 270-degree anti-clockwise rotation. The normal gut rotation is 270-degree anti-clockwise in total, which is in 3 phases, 90 plus 90 plus 90. So this is about the normal rotation. Now with that, let's now talk about some anomalies which are related to the rotation, the non-rotation, malrotation, reverse rotation, omphalocele. So let us also talk about that part. Case 1. Herniation takes place. First rotation 90-degree anti-clockwise is normal, like always. And then there is no second rotation or third rotation. Imagine there is a reduction of the hernia without second or third rotation taking place. So only first rotation took place, but not the second and third. So what you will see that my small intestine will be toward what side? Toward the right side. And my large intestine, that is ascending and descending colon, both will be present on what side? Toward the left side. So when you see the small intestine toward the right side and large intestine toward the left side, that is because of the condition called as the non-rotation. Although first rotation took place, we still call it non-rotation. Only first rotation took place, second and third rotation is absent, followed by the reduction of hernia, small intestine to the right, large intestine to the left side. That is a case of non-rotation. So guys, case 1, we said the case 1 is a case of non-rotation. Case 1, that is a case of non-rotation. So what was non-rotation? In the non-rotation, first rotation is normal, right? The first rotation is normal. Second and third rotation are absent. We got absent second and third rotation, and because of absent second and third rotation, when the reduction of hernia takes place, the small intestine is on the right side, whereas the large intestine will be seen on the left side. That's the final picture you have to remember. Even if you don't remember that what is the reason behind it, you just at least remember that what is the final scenario. So when the small intestine is toward the right side and large intestine is toward the left side, that is the case of non-rotation. If I may just draw it for you. Here's the small intestine, that is ascending colon, the descending colon. So look at this. This is a superior mesenteric artery, right? That is a superior mesenteric artery. And that's what you're looking at. That is pre and the post arterial segment. The post arterial segment, that is a large intestine, which is present very much on the left side. Both ascending and descending colon are on the left side. So it could be a good potential image-based question also. So this is the non-rotation, when the small intestine stays on the right side and large intestine on the left side. Case 2. Herniation takes place. First rotation is normal, again 90-degree anti-clockwise. But look at this. After first rotation in 90-degree anti-clockwise rotation, the second and third rotation, that is total of 180-degree rotation. That 180-degree rotation takes place in the clockwise direction. It was supposed to go into anti-clockwise, but now after first rotation is normal, second and third rotation, that is the next 180 degrees of rotation, it takes place in the clockwise direction. And this time the post-arterial segment comes back to the abdominal cavity, and that will be followed by the pre-arterial segment. That means our small intestine will be the one which is overlapping the large intestine. This is a transverse colon. That is a transverse colon, or you can say large intestine, and that is overlapped by the small intestine as well as superior mesenteric artery. Just see it once again. Herniation took place. First rotation is normal, followed by 180 degrees of clockwise rotation. Post-arterial segment came back in, followed by the prearterial segment, large intestine overlapped by the small intestine, as well as superior mesenteric artery will be in front. Can compress the transverse colon also. That condition is called as what? That is called as a reverse rotation. It's a reverse rotation. Imagine 90 minus 180. That means minus 90, isn't it? It goes to minus 90. So that is called as a reverse rotation. The reverse rotation, when you see small intestine is present in front of the transverse colon or and along with superior mesenteric artery. The second case we'll talk about is the case of reverse rotation. Case 2, that is a case of the reverse. Now what happens in reverse rotation? The first rotation is normal again, right? The first rotation is normal, 90 degree anti-clockwise. And then it is followed by the 180 degrees of clockwise rotation. The second and third rotation basically are going clockwise. So that's the point here, that the 180 degrees of clockwise rotation. Moreover, the post-arterial segment returns to abdominal cavity before prearterial. The post-arterial segment returns to abdominal cavity before the prearterial segment, and that will result into the picture where the transverse colon, that is large intestine, transverse colon is overlapped. The transverse colon will be seen overlapped by the small intestine, that is duodenum basically, and also by the superior mesenteric artery. Once again, this final picture is important. The transverse colon is overlapped by the superior mesenteric artery and small intestine. This will be something like, if this is the small intestine here, you can see the transverse colon is present behind this duodenum part, right? This is what is happening here. Even superior mesenteric artery is in front. Look at that. That is a superior mesenteric artery which is in front. And as a matter of fact, the obstruction of the transverse colon in this case is mainly because of superior mesenteric artery. Although duodenum is also present in front of it, but the obstruction of the transverse colon in case of reverse rotation is mainly due to superior mesenteric artery. So the main culprit here is superior mesenteric artery which is passing in front. So there is a case of the reverse rotation. After first rotation, there is like 180 degrees of clockwise rotation, and the post-arterial segment come back first, followed by the pre-arterial segment. So our large intestine is behind and the small is in front there. That's a case of reverse rotation. Case 3, herniation takes place. Let's say first rotation is normal and even second rotation is also normal. It's an anomaly of the third rotation, guys. When the reduction of hernia takes place, we said the third rotation will also be there. So it's an anomaly of the third rotation. So it is absent third rotation. There is no third rotation and there is a reduction of the hernia. So the cecum is actually not going toward the right side. The cecum will stay in the midline only. The cecum comes back into the midline position, and that is called as a subpyloric cecum. Subpyloric cecum is a condition in which the cecum is present in the midline. You can call it epigastric cecum also. It is a type of malrotation. First rotation normal, second rotation is normal, but the third rotation is not present, and the reduction of hernia is obviously there, but the cecum, instead of going toward the right side, it comes into the midline. That is called as a subpyloric cecum or the midline cecum. It is one of the type of malrotation. Coming to case 3, in case 3, what happens is, it is a case of the malrotation. It is one type of malrotation in which you will see the midline cecum or subpyloric cecum. It's a type of malrotation in which you will see the subpyloric or midline cecum. Now, how is it possible? If the first and second rotation, let's say both first and second rotation are normal. First and second rotation are normal. And we have third rotation is absent. First and second rotation are normal and third rotation is absent, and obviously there's a reduction of hernia as well. That will lead to this subpyloric cecum. The subpyloric cecum, which is also called as an epigastric cecum. Subpyloric cecum or the epigastric cecum. There is a case of subpyloric cecum or epigastric cecum. You know, the thing about this subpyloric cecum or epigastric cecum is sometimes what you'll see, there is a presence of a band called as LAD band, which can be seen attached to the cecum. If it is present in the midline, if the third rotation is not present, that band can actually cause the obstruction of the duodenum. What I'm saying is, if this is the, let's say the cecum here in the midline, so let's say this here is the duodenum here, and then we have this all this large intestine and small intestine. The cecum is somewhere here in the midline. All this ascending, descending colon and everything is something like this. So what I'm saying, there is a peritoneal fold which can be seen from the cecum, and that peritoneal fold is overlapping the duodenal part. If the rotation would have taken place, this band would not be there. The band would have been absorbed in the posterior abdominal wall. But because the cecum is midline, and if there is any absorption in the midline, this band, the so-called LAD band, this LAD band can cause the compression of this duodenum, can cause this duodenal obstruction also. So cecum is having this peritoneal fold attached to it. As I said, if the rotation would have taken place, this absorption of peritoneum will be there and the cecum will become retroperitoneal. But because third rotation is not present, so cecum is in the midline, the subpyloric cecum, as you can see somewhere in the midline here, and you will see a peritoneal fold which can be seen passing in front of the duodenum and attached to cecum. So any absorption of this band in the midline can cause the duodenal obstruction also. That band is called as a LAD band. I hope you read about the LAD band resection in the surgery also. This is a LAD band which can be seen, one of the complication in case of the malrotation or subpyloric cecum. Case 4. Herniation takes place and it never comes back. Now when the herniation takes place through the umbilical opening, and if it is not coming back into the abdominal cavity, that means umbilical opening will never close because the intestine has not come back. And that condition is called as an omphalocele. You will see a baby born with the small intestine or the midgut loop which are protruding out of the umbilical opening only. That is called as an omphalocele. That is omphalocele. Whereas case 5, in which the herniation takes place, there is a reduction of hernia also. The umbilical opening will close and will be in normal in position. But you will see that midgut loop again herniating out, not from the umbilical opening, but from the defect in the anterior abdominal wall. So you will see the intestinal loop emerging out of the defect in the anterior abdominal wall, and that defect is because of the incomplete lateral folding of the embryo. If there is not a complete lateral folding of the embryo, anterior abdominal wall will not completely form. There will be defect in that, and that herniation and that protruding of the midgut loop from that will be called as a gastroschisis. So got an omphalocele and the gastroschisis. These are the two anomalies you should be able to remember and should be able to differentiate between them. That is omphalocele and the gastroschisis. And now coming to the last, that is case 4 and 5. As we just discussed, case 4, that is the case of omphalocele, when the herniation takes place and it fails to return. So omphalocele is basically failure of reduction of physiological hernia. That is because of the failure of reduction of physiological hernia. That is causing the omphalocele. But in case of gastroschisis, it is kind of the reherniation from the defect in the anterolateral abdominal wall, or simply in the anterior abdominal wall. So it's not from the umbilical opening, it is from the defect in the anterior lateral abdominal wall. One other important thing about the omphalocele is that omphalocele is usually seen. It is usually seen with multiple anomalies. It is usually seen with multiple anomalies. I mean, isolated cases of omphalocele are rare. When you see the omphalocele cases, they are like multiple anomalies are there. Some cardiac defect might be there and all. And that is why the mortality rate is quite high in case of omphalocele, because there are a lot of other anomalies which can be seen in the embryo at the same time. Whereas in case of gastroschisis, the important point to note is we said it is because of the defect in the anterior abdominal wall. And why the defect is there? Because of the incomplete lateral folding of the embryo. Incomplete lateral folding of the embryo is the reason behind this gastroschisis. So these are the two cases. One is omphalocele and one is a gastroschisis. Omphalocele is, as I said, failure of reduction of hernia, and gastroschisis is the herniation from the defect in the anterior abdominal wall, because the anterior abdominal wall is not formed completely, as the defect is left in the anterior abdominal wall because of incomplete lateral folding. So coming to the third part, guys, that is hindgut and urogenital system. So let's now talk about the hindgut part and also about the urogenital system. Well, these two will go hand in hand. If you remember from the very first picture we discussed in this GIT embryology, when we talked about the folding of the embryo. So we said hindgut is having a ventral extension. Let me start from that point only. That was a hindgut. And here is the ventral extension from the hindgut, and that is called as what? Allantois. So this obviously is the hindgut part. The extension is the allantois. Allantois actually gives rise to the bladder in lower animals. Like birds, the allantois form the entire bladder in birds, but in human we just have the remnant. And if you remember, the portion below the allantoic diverticulum, this portion was the cloaca. Right, this portion was the cloaca part here. And this cloaca, or this portion of the hindgut, is going to be divided in two parts by a septum called as a urorectal septum. But even before I talk about the urorectal septum, from the general embryology, do you remember what was the membrane present at the caudal end of embryo? That was a cloacal membrane. This cloaca here, and that membrane was a cloacal membrane. So let us say, guys, this here is the cloacal membrane. If I say this is the cloacal membrane. So what is now going to happen? That there is a septum which will develop. Now look at this arrow here that is representing the septum. The septum will grow, and this divides the cloaca in two parts. That's how it is going to grow. And this septum is made up of extra embryonic mesoderm. This is made up of extra embryonic mesoderm. The septum is called as urorectal septum. This septum is referred as a urorectal septum. It is dividing the urinary bladder from the future urinary bladder to the future rectum and anal canal. So we call it urorectal septum. So once this urorectal septum, which as I already said is made up of extra embryonic mesoderm. Remember extra embryonic mesoderm, which was all around the yolk sac. So that extra embryonic mesoderm. And once the urorectal septum will completely divide this cloaca part, now we have the two different entity. This anterior part, look at where I'm highlighting here. This anterior part, guys, this will be called as a urogenital sinus, because that portion of the cloaca will give rise to the urinary structure like bladder, and to some genital structures also. The genital ducts will come into it. And the posterior part here will be called as primitive rectum. So let me draw that next picture. So what I'm saying is that the next image would be something like this. This is the portion which is the anterior part with the allantois, and that is the posterior part, the primitive rectum part. So the septum has already grown inside, I'm not drawing it again. And even the membrane is divided in two parts. The cloacal membrane itself is divided in two parts as well. Look at that. So now we have two different entities, guys. This is called as the primitive rectum, the one that you see behind. This is the primitive rectum. And the one here, this is called as the urogenital sinus. We have a pelvic part, we have a phallic part of that. Pelvic part is above, phallic part is below. So that is urogenital sinus. Allantois will be obliterated and will give rise to urachus. And we have a remnant, that obliterated allantois or the urachus, that forms a ligament in human, and that ligament is called as the median umbilical ligament. There is a median umbilical ligament. If you look at the bladder, at the apex of the bladder, there is a ligament called as median umbilical ligament. We do have a medial umbilical ligament also, but this is median, and in the middle goes to the umbilicus. And if this urachus is patent, let's say, if this urachus is patent, then the bladder will be seen having a connection directly to the umbilicus. That leads to the weeping umbilical cord. If there is a patency of this urachus, that can lead to the weeping umbilical cord. The urine can be dribbling out of this umbilical opening. So now we already divided this in two parts. So this is the urogenital sinus, which is present anteriorly, and primitive rectum behind. And not only this, we have membrane divided in two parts. Now the membrane in front, that membrane is also called as the urogenital membrane. This membrane is urogenital membrane, and the one behind that is called as the anal membrane, because it obviously will contribute to the formation of anal canal. So it all started with that hindgut part having the allantoic diverticulum. The portion below that allantoic diverticulum was cloaca. The cloaca was divided in two parts. Anterior part is urogenital sinus, posterior part is primitive rectum. And urogenital sinus, as we just said, we'll discuss it more, will give rise to the urinary and genital structures. Primitive rectum, well, primitive rectum obviously will give rise to rectum. But what about anal canal? If I do it here itself, guys, anal canal. If you look at the anal canal, well, the main landmark that we have in the anal canal, that is the dentate line, which is the lower limit for all these. That is a dentate line, which is the lower limit for the anal columns, anal valve, anal sinuses, right? All these things. And this part, which is above the dentate line, all these ollum, anal canal, the portion above the dentate line, that is the, which is having all these sinuses, anal valve and everything, they're all derived from primitive rectum. They're all derived from primitive rectum. And see, where the primitive rectum is coming from? Primitive rectum is from the hindgut. Hindgut, remember, it was from the yolk sac. And yolk sac is what? Endodermal. So this portion of the anal canal is endodermal part, which is contributed by the primitive rectum. On the other hand, anal membrane, which is coming from cloacal membrane. So this anal membrane will form the lower part of the anal canal, and that part is the ectodermal part of the anal canal. That will give rise to the ectodermal part of the anal canal. So above the dentate line, everything that we have, as we said, the columns, valve, sinuses, they're all endodermal. And everything below the dentate line will be ectodermal, and that is the ectoderm of the anal membrane, which is ultimately coming from cloacal membrane. So that is about the anal canal. For the urogenital sinus, now we have to discuss it separately. Let me take you back to something where we talked about the intermediate mesoderm, where we said there are three types of mesoderm. We have paraaxial, intermediate, lateral plate mesoderm, and we did not talk much about the intermediate mesoderm. We just wrote that intermediate mesoderm will give rise to some urinary structure, some genital structure, urogenital system, and this sinus is urogenital sinus only. So now this is time to connect that intermediate mesoderm we discussed in the general embryo to this urogenital sinus, and let's find out how exactly there is a development of kidney to the uterus, vagina, all will developing from this part itself. That will do it in this next section. To discuss the development of the urogenital system, the two important things which are required, one is the urogenital sinus, we just talked about it, and one was the intermediate mesoderm, which we talked about when we saw that how the intraembryonic mesoderm divides into paraaxial, intermediate, and lateral plate mesoderm. So guys, for the development of the urogenital system, as I said, one we need is the urogenital sinus. Urogenital sinus, obviously it is endodermal. Urogenital sinus was a part of the hindgut, so it is endodermal. And another thing that we need here is the intermediate mesoderm. That is intermediate mesoderm. Why this intermediate mesoderm? What this intermediate mesoderm will do? Intermediate mesoderm will further divide in or give rise to two things. One is the genital ridge. One is the genital ridge and also the nephrogenic cord. Genital ridge and nephrogenic cord. These are the two parts which we need to focus at for now. Genital ridge and the nephrogenic cord. Well, genital ridge will give rise to what? If you remember, we talked about this. We use this term in the general embryo also. Genital ridge is to give rise to the gonads. Testis and ovary will be derived from this genital ridge or gonads. That is intermediate mesoderm. Whereas the nephrogenic cord, as the name suggests, nephrogenic cord is the part from where all these kidney and other things will develop. So nephrogenic cord is the portion which will divide into the pronephros and mesonephros and metanephros, and then other that we'll see that how exactly the kidney will come into the picture. So I can say nephrogenic cord is a portion from where the future kidney, even ducts like mesonephric duct, paramesonephric duct, all these events will take place, their formation event will take place in the nephrogenic cord. So guys, let us understand what we have and how exactly it will act to form this genital system and urinary system as well. Now look at me. Let's say these are the two intermediate mesoderm we have, like this one intermediate mesoderm here and one here on the posterior wall, posterior embryonic wall, starting from all the way from the cervical region till lower down. So that is intermediate mesoderm. And then we have urogenital sinus present in front. We just said hindgut is divided into two parts by the urorectal septum. So it is divided by the urorectal septum in what two parts? Anterior was the urogenital sinus and posterior was the rectum. So urogenital sinus relatively is present in front, and we have the two intermediate mesoderm which is on the posterior wall. So let us say if mesonephric duct develops in this intermediate mesoderm, in the nephrogenic cord more precisely, that mesonephric duct or paramesonephric duct will go into the urogenital sinus from which wall? From the posterior wall. And that is why the trigone of the bladder is seen in the posterior wall, because all the absorption of these ducts are taking place from the posterior aspect only. So it's imperative to understand that what raw material we have with us. So I'm going very schematically about it. Let us say this is a nephrogenic cord of one side. Let's keep it very simple. That is a nephrogenic cord of the other. So this whole thing here is a nephrogenic cord. Let me write in short now. That is nephrogenic cord. What is nephrogenic cord? It's apart from the intermediate mesoderm only. So there is a nephrogenic cord. And this here is the urogenital sinus which is in front. Let me put it like this. This is a urogenital sinus. Urogenital sinus, which is all about endoderm. So this is something which is to be decided in the beginning only. This is intermediate mesoderm. If nephrogenic cord is an intermediate mesoderm, that means anything which will develop in the nephrogenic cord will be mesodermal only. And similarly, urogenital sinus comes from where? Comes from the cloaca. Cloaca from the hindgut, hindgut from the gut, gut from the yolk sac, and yolk sac is endodermal. So just keep that in mind, that whatever we are going to discuss, we have the two main components here. One is mesodermal and one is endodermal. In the development of kidney, they say that ontogeny repeats phylogeny. When the development of kidney begins, it's not the human kidney which directly comes into the existence. The very first primitive type of kidney, which actually develops in the cervical region, cervical part of this nephrogenic cord, called as a pronephros part, that is more of a kidneys in fishes, which obviously will not work for the human. The second type of kidney, which is more effective than the pronephric kidneys, is more like an amphibian kidney, that is from the mesonephros, will develop from the thoracolumbar region of the nephrogenic cord. That will also not be successful, because there is one issue with the mesonephric kidney. There is no reabsorption possible in the mesonephric kidneys. No peritubular capillaries, no vasa recta. So that is not possible. And that is why the human kidney finally developed from the caudal part of nephrogenic cord, that is the metanephros part of this nephrogenic cord. So that also explains you that why kidney develops in the pelvic fossa, because the kidney developing in the upper primitive cervical region and the primitive thoracolumbar region fails, and the successful human kidney is metanephric kidneys, which is from the caudal part of nephrogenic cord. So guys, let's presume this is the cranial part of nephrogenic cord, that is the pronephros. The middle part of nephrogenic cord, that is the mesonephros. Well, I said mesonephric kidneys will not be successful in human, but that doesn't mean the mesonephros is not successful at all. Mesonephros gives rise to mesonephric duct, and then we have paramesonephric duct. So mesonephros is very much needed in human, but when it comes to kidney will not develop from the mesonephros. It is from what part? It is from this caudal part of the nephrogenic cord, which will be separated entirely, and we call it what? Metanephros. That is a metanephros part. So let's say this here is the metanephros part from where the kidneys will develop. We'll discuss that eventually. And that is the reason human kidneys are also called as the metanephric kidneys. They develop from metanephros, so we call it metanephric kidneys. Well, we'll come back to that point. Now, mesonephros, we said mesonephros will give rise to the mesonephric duct and paramesonephric duct also. So guys, let us say, if this is a mesonephric duct here, now the mesonephric duct will come from this mesonephros and will come forward and get absorbed in the urogenital sinus later on, and that will give rise to the trigone of the bladder. That will give rise to the trigone of the bladder. So I can say, in the initial development, this here is a trigone of the bladder. I can say that this duct, this is called as a mesonephric duct. As you can say, it is descending from the mesonephros. It is formed in the mesonephros. So this duct here is a mesonephric duct. Let me highlight that for you. That is a mesonephric duct. Very important. And this mesonephric duct will eventually get absorbed into the urogenital sinus to form the trigone of the bladder. But this is like a next step. I'm just going in a retrograde manner. But when it comes to the development of the kidney, I saw this trigone first. But when you look at the kidney, we said kidney will develop from metanephros. Now, how it will develop from metanephros? There is one bud which you will see extending from this mesonephric duct, and that bud will go back and invade the metanephros. I'm going to draw it separately, just to show you that how this bud will come out. This bud is called as a ureteric bud. This bud here is called as a ureteric bud. And you can see the ureteric bud invading into the metanephros part above. Let me just take this portion here separately so that I can explain you this thing even better. So guys, if this is the metanephros part, if this here is a metanephros part, let me give the same color to that. That is a metanephros. From above we have that mesonephric duct coming, right? Let me draw it with a lumen. So let's say there's a mesonephric duct here. And we just said that mesonephric duct will give rise to this bud called as a ureteric bud, which goes back and invade the metanephros. This is the mesonephric duct. This obviously is a metanephros, no doubt about that. And this bud here is there is a ureteric bud. And once this ureteric bud invade the metanephros, this metanephric tissue present around this ureteric bud, it starts proliferating. And this proliferating metanephric tissue, guys, this is called as the metanephric. This is called as the metanephric blastema. This is referred as the metanephric blastema. So basically, for the development of kidney, we have two things with us. One is metanephric blastema, which is from metanephros, and we also have this ureteric bud. The ureteric bud, which is derived from the mesonephric duct. Good thing in kidneys, we don't have to bother about endoderm, ectoderm, mesoderm. Everything is mesodermal only. Metanephros is mesoderm. Mesonephric duct coming from mesonephros is also mesodermal. So ureteric bud is also mesodermal. So it's all mesoderm. But still the question is asked that what precisely is derived from the metanephric blastema and what is derived from the ureteric bud. So when you say metanephric blastema, it is actually giving rise to the secretory portion of the kidney. If in one word I say, it will give rise to the secretory portion of the kidney, whereas a ureteric bud, it forms the collecting portion or the collecting part of the kidney. So broadly speaking, the secretory part of the kidney or secretory portion of kidney comes from metanephric blastema, that is, you can say ultimately from metanephros, whereas ureteric bud will give rise to the collecting portion of the kidney. Now when I say secretory portion of kidney, I mean to say Bowman's capsule, PCT, loop of Henle, DCT, and even connecting tubules. Remember this word, guys, connecting tubule. Be careful. Connecting, not collecting. Connecting tubules is coming from the secretory portion, that is from the metanephric blastema. But the collecting portion of the kidney I was talking about, this will give rise to the collecting tubule. This will give rise to the collecting tubule. It will give rise to the renal papillae, major and minor calyces, all collecting portion, major and minor calyces. It will give rise to the renal pelvis. Renal pelvis. It will also give rise to the, obviously, to the ureter. That's a ureteric bud we are obviously talking about. So even ureter is derived from this ureteric bud. So all the collecting portion of the collecting portion of the kidney is coming from the ureteric bud, and the secretory portion is all derived from PCT, loop of Henle, DCT. All this is derived from the metanephric blastema. Just as I said, just be a bit careful about this connecting and the collecting thing. And they recently asked this question that the epithelium of ureter is derived from where? Well, you can say ureter is here, right? So epithelium of ureter is derived from where only? That is from the mesonephros. It's invading the metanephros, but derived from where only? From the mesonephros. Mesonephric duct gives rise to the ureteric bud. So ureter, epithelium of ureter is derived from what nephros? That is mesonephros. And not only ureter, everything in the collecting portion. The epithelium is derived from where? From the mesonephros. That was one of the recent question only. That epithelium of ureter is derived from where? It is from the mesonephros. So guys, we're done with the kidney. We're done with the ureter. Now we already said that the mesonephric duct is getting absorbed inside and giving rise to the trigone of the bladder. Well, trigone of the bladder is also mesodermal. Developmentally it is mesodermal, but you can note one thing, that later on, as per Langman says, later on the epithelium of the urogenital sinus, the same epithelium which is covering the urogenital sinus, the endodermal lining that will be having, will also cover the trigone of the bladder. So ultimately, I would say in adult bladder, entirely interior of the bladder is by the endoderm of urogenital sinus. So initially during the development, it is endodermal mainly, you can see. During the development, look at this red color here. So I can say the bladder is endodermal, correct. Trigone is mesodermal because it is derived from the absorption of mesonephric duct, correct. But later on, the urogenital sinus lining, the endodermal lining of the urogenital sinus will cover the trigone also. So at the end, the picture is that everything in the bladder is actually endodermal. The entire lining of the bladder will be endodermal. So guys, kidney done, ureter done, bladder done, and the trigone and all. Let's go further in that. So let me take the same picture, this urogenital sinus, and talk about the development of the urethra, and especially the questions are asked on the male urethra. So let's also talk about the development of the male urethra. So I'm going to stick to the same color code. Let's say this here is the urogenital sinus. And here is the extension of this urogenital sinus. So this obviously will be the prostatic urethra. If this is a prostate gland, let's say this black color here represents the prostate gland. Let me put a different color for that here. So this is a prostatic urethra. That is the extent of the prostatic urethra, followed by the small membranous urethra, which is present in the deep perineal pouch. That is a membranous urethra. Then we have this long penile urethra or spongy urethra. And then we got this terminal urethra, which is present in the glands. Prostatic, membranous, spongy, and here is the terminal urethra, which is present in glands. The terminal urethra which is present in the glands. So guys, this was the urogenital sinus. That's what we said, the urogenital sinus, and we already know that urogenital sinus is all about endoderm, that is endodermal extension. Whereas, look at this, the trigone part inside, which initially was found by the mesoderm. Now, trigone is found by the absorption of mesonephric duct. Well, not only the trigone, there's an extension of this, or you can say the absorption of mesonephric duct goes even further downward in the prostatic urethra till the opening of ejaculatory ducts. This is all about the absorption of what duct? Mesonephric duct, which obviously is mesodermal. That is a mesonephric duct absorbed, forming a trigone, or later on it is covered with endoderm. Okay, that is a different thing. But the same absorption of mesonephric duct even goes into prostatic urethra. You can see it is going into the prostatic urethra till the ejaculatory duct. These are the ejaculatory ducts. These are ejaculatory ducts. So just by looking at this picture, I can make out that prostatic urethra, guys, this prostatic urethra, yes, it is made up of endoderm. You can see that red color there indicates the endoderm. But we also have mesoderm in the prostatic urethra. And where is the mesoderm? On which wall? On the posterior wall. Till where? Till ejaculatory ducts. So posterior wall of prostatic urethra till the opening of the ejaculatory duct, it actually is formed by the absorption of mesonephric duct only, so it is mesodermal. Membranous urethra, on the other hand, is purely endodermal. Spongy urethra is also purely endodermal. The penile urethra, the longest part, that is also endodermal. And here's the point. The terminal urethra, this one, the one which is opening in the glans penis, this portion is ectodermal. This portion is ectodermal. Why it is ectodermal? Because glans penis and clitoris, they are derived from something called as genital tubercles. And those genital tubercles are ectodermal thickenings. So obviously urethra opening into an ectodermal thickening will be ectodermal only. So male urethra is mainly it is endodermal, you can see that, but we do have a mesoderm very much in the proximal part on the posterior wall, and we also have ectoderm in the terminal part of the male urethra, the one which is opening in the glans. So we have all three, endoderm, ectoderm, and you can see there is a mesoderm also is there. That's a special feature of the male urethra, having all three components, and you should know precisely that where is what, endoderm being the dominant component. Now tell me something, guys. What about female urethra? I mean, out of this endoderm, ectoderm and mesoderm, which component should not be there in the female urethra here? Well, mesoderm will be there because trigone is forming in the female bladder also. So the same mesonephric duct will be coming down. We got a urogenital sinus there also. Ectoderm will not be there. Now, why ectoderm is not there in the female urethra? Because male urethra is ectodermal because it is opening in what? It is opening in the glans penis. Female urethra is not opening in clitoris. Clitoris is ectodermal, but urethra is not opening in the clitoris. So there is no ectoderm in female urethra. So we only have mesoderm on the posterior wall and rest is endodermal. If I just make a small note here, talking about the female urethra. In case of female urethra, mesoderm on the posterior wall and endoderm on the anterior wall. In fact, rest everything is endodermal except that posterior wall. So we have meso and endo, but there is no ectoderm in female urethra. Okay. Now, we also have some direct questions asked. These are kind of one-liners which are asked on that what is derived from the genital ridge. We use one term called as genital tubercle. Then there is something called as genital swellings and also called as genital folds. So let me just put all these four terminology in front of you. Genital ridge. Well, something which we just talked about. Genital ridge will give rise to gonads. So genital ridge are the one which gives rise to testis or ovary. Then we use one term called as genital tubercles. Genital tubercles are the one which will give rise to the glans or clitoris. Then there is this genital swellings. Genital swellings. Genital swellings will give rise to the scrotum in male and labia majora in female. And then finally one more term that you should know, that is genital folds. Genital folds are also called as the urethral folds. Genital folds or the urethral folds. And these genital or urethral fold in male, they will give rise to the ventral aspect of the shaft of the penis. So they'll form the ventral aspect of penis. And in female, they'll give rise to the labia minora. Some direct one-liners. Genital ridge, tubercle, swellings and folds. Remember that? Ridge, tubercle, swellings and folds. So guys, this is about the course of the mesonephric duct and what will it give rise to. The kidney, the certain structures which are common in both male and female. Okay, now talking about the paramesonephric duct, and then we'll also see the remnant of both meso and paramesonephric duct. Paramesonephric duct is having almost the same course, but first of all we call it paramesonephric duct. Even if you get an image-based question on that, remember mesonephric duct is more inside and para is outside. That is paramesonephric duct. Paramesonephric duct is a main duct for female, and the difference is that mesonephric duct came down and it invaded the urogenital sinus from the posterior wall, but individually. Right separate, left separate. Paramesonephric duct will come down, will meet with each other, forms a common duct, and that invades the urogenital sinus to form the fallopian tube and the body of the uterus. So when we talk about the fate of the paramesonephric duct, The paramesonephric duct. So I got to go with the same thing. This is the paramesonephric duct of the, let's say, the right side, and we have this paramesonephric duct of the left side. And then this paramesonephric duct, it is invading this urogenital sinus. So these are the paramesonephric duct of the right and the left side, and this here is the urogenital sinus. Well, obviously paramesonephric duct, again mesodermal, urogenital sinus endodermal. And this proliferating end of this paramesonephric duct, this is what you call as the this is called as the sinovaginal bulb. That is the sinovaginal bulb. It's called a sinovaginal bulb. So the ultimate picture would be, if I just go directly to that final picture using the same color code, that paramesonephric duct will give rise to the fallopian tube. It will give rise to the fundus, body of the uterus, cervix, vaginal fornices and upper vaginal wall, and lower vaginal wall, it is derived from the urogenital sinus. So look at this, guys. This portion here till the upper vaginal wall, the fallopian tube, fundus and body of uterus and the cervix and the vaginal fornices. So all this is derived from the paramesonephric duct, which is mesodermal, whereas the lower part of the vagina, that is derived from the urogenital sinus, and that obviously will be the endodermal. That will be endodermal. So this is the fate of the paramesonephric duct in female. Well, it's a main duct for the female, and we just have remnants in case of the male. So let us talk about that, what remnants we have for the mesonephric duct and what remnants we have for the paramesonephric duct. And even before looking at that list, now we can just think about it. When you say mesonephric duct we just discussed is giving rise to the ureteric bud, which is required for both male and female. Mesonephric duct is forming the trigone of the bladder, again required for both male and female. Mesonephric duct is also getting absorbed even below and giving rise to the posterior wall of the urethra, again both in male and female. So till this point their derivatives are common. But beyond this point, the mesonephric duct is required in what? It is required in male or female? Well, it is required in male, because mesonephric duct also have to form the spermatic pathway. The vas deferens, epididymis, all that will be derived from where? From the mesonephric duct only, whereas paramesonephric duct will just have a remnant in case of the female. So look at this list here, and I would like you guys to please take it down. I mean, I'll give you enough time to write it down as well. Look at these derivatives and the remnants of the mesonephric duct and the paramesonephric duct. Now, let me just first try to justify these. Mesonephric duct, which is also called as Wolffian duct. So what are the derivatives we have, guys? Posterior wall of prostatic urethra in male, and similarly we have posterior wall of urethra in female also. Ureteric bud derivative in male, ureteric bud and derivative in female also. Trigone and trigone in female also. So till here it's all common. But beyond this point, look at this. We said in male it will give rise to the spermatic pathway. So all this spermatic pathway, including this appendix of epididymis, this is all derived from the mesonephric duct. Vas deferens, ejaculated duct, the epididymis. Now what is appendix of epididymis? If you look at the testis, and this is the head of the epididymis, so you will see a small extension there that is called as an appendix of epididymis. That is also the remnant of the mesonephric duct. Whereas in case of female, mesonephric duct will give rise to what? It will give rise to the duct called as a Gardner's duct or duct of Epiphoron. And please be careful if the question is asked, what is the location of the Gardner's duct? Well, the question may be asked on the Gardner's cyst, which is in the upper vaginal wall. But if the question is asked on the Gardner's duct location, it is present between the two layers of broad ligament. Remember that. It is present between the two layers of broad ligament. So be careful whether the question is on the Gardner's cyst or the Gardner's duct. Gardner's cyst is present in the upper vaginal wall. Gardner's duct, which is a remnant of the mesonephric duct, is derived from the is present in the broad ligament, between the two layers of the broad ligament. So this is about the derivatives of the mesonephric and the mesonephric duct and the remnant. Similarly, paramesonephric duct, guys, what are the derivatives and the remnant of the paramesonephric duct? Well, there is nothing much in that. When I say paramesonephric duct or Mullerian duct, only female derivatives. You got a fallopian tube, the uterus, and the upper part of vagina. We just discussed that. They're all derived from where? From the parameso. In the male, just remnants. Appendix of testis and the prostatic utricle. Appendix of testis. Just be careful, guys. Appendix of epididymis is derived from something which is giving rise to epididymis. That is mesonephric duct. This is appendix of testis we are talking about. That is derived from the paramesonephric duct along with prostatic utricle. What is prostatic utricle? I mean, if you look at the prostatic urethra, which we'll discuss separately also, if there is a prostatic urethra, you have two ejaculated ducts, and between the two ejaculated ducts there is one blind opening. This blind opening on the posterior wall of the prostatic urethra is called as the prostatic utricle. And you know, the prostatic utricle actually corresponds to the uterus and vagina in female. So it's like a remnant of the structures which is giving rise to uterus and vagina in the female, and that remnant is in male also. So sometimes we also call it the masculine vagina. The prostatic utricle, it can also be referred as the masculine or the male vagina. So that is about the derivatives of the mesonephric duct and the paramesonephric duct. And with that, we conclude the development of the GIT as well as the urogenital system. So guys, in this section we will be talking about the gut development. We'll talk about the GIT and urogenital system. So first let us start with the GIT, which we'll be discussing in three parts. We'll talk about the development of foregut, followed by the midgut and the hindgut. And while discussing the hindgut, we will also talk about the development of the urogenital system. So let us talk about the development of GIT and the urogenital system. It's another important section of the embryology from where you can expect questions, especially from the gut rotation part. That is very, very important. So let me take you back to this general embryo where we left. So what we have with us now, that there is a paraxial mesoderm, we got an intermediate mesoderm, we have a lateral plate mesoderm also, and lateral plate mesoderm was divided by the coelom, that is called as a intraembryonic coelom. And the portion which is present below, the yolk sac. Now, if you remember, we said the primary yolk sac will turn into the secondary yolk sac once a big part of the primary yolk sac is pinched out in the process of the formation of extraembryonic coelom. So, portion of the yolk sac was taken away. Now, again, a part of the yolk sac will extend out, or it will taken off or taken away during the folding of the embryo as well. And whatever yolk sac will be left inside, that yolk sac will be the definitive yolk sac, which you can divide into the foregut part, midgut part, and the hindgut part also. So I'm going to start with the picture showing you the folding of the embryo, where you can also appreciate these extensions of the gut tube. So there we go. This is let us say this is the folding of the embryo you're looking at, right? And here we got this yolk sac. So what you see, the extensions of the yolk sac being, one is the vitellointestinal duct. This is a vitellointestinal duct. And the second extension that you see from the caudal part, from the hindgut part, that is the allantois. So as I said, we can broadly divide the gut tube first into these three parts. This is a yolk sac which now divided into the foregut, the midgut, and the hindgut. So you can see one extension coming from the future, this midgut part of the yolk sac, and one extension you can see coming out from the hindgut part of the yolk sac. And these extensions are protruding into this umbilical opening. What extensions are these? This is called as allantois. That is allantois. And this here is the vitellointestinal duct. That is vitellointestinal duct. So we got allantois and vitellointestinal duct, the two extensions that you see coming out from here. So we have foregut, midgut and hindgut, and you can see the two extensions going into the umbilical cord, which tells you that these are the contents of umbilical cord also. When we talk about the contents of the umbilical cord, it's not only the Wharton's jelly or the umbilical vessels, even these are considered as the contents of the umbilical cord. So if I may write for you, that is the umbilical cord. That is the umbilical cord. So the contents of the umbilical cord will go like this. Like we have two umbilical arteries. There will be two umbilical arteries. We'll have left umbilical vein. The right one disappears. We'll discuss that in the cardiovascular system also. So we got a left umbilical vein. Then obviously the Wharton's jelly will be there. Wharton's jelly. We will also have these two things that we just discussed, that is allantois, and number 5, that is vitellointestinal duct. Vitellointestinal duct. These are the structures which you see present inside the umbilical cord. So these are the contents of the umbilical cord. So we got two umbilical arteries, left umbilical vein, Wharton's jelly which is made up of that extra embryonic mesoderm only. Remember we said umbilical cord is an extension of the connecting stalk. And if you remember from the general embryology, connecting stalk was nothing but undifferentiated extra embryonic mesoderm. When the coelom was forming outside this yolk sac and amniotic cavity, that was extra embryonic coelom. But that extra embryonic coelom was is not extending to one region, and that was connecting stalk. So that same connecting stalk is now umbilical cord. So whatever you're looking at, all these connective tissue that we have inside the umbilical cord is made up of that undifferentiated extra embryonic mesoderm. So well, this is just about for the beginning only, that we have now foregut, midgut and the hindgut part, and these two extensions you should remember that which part they are coming from. Let me also clarify one more terminology here. This whole thing is called as hindgut, and then you see from the ventral part of the hindgut we have the allantois coming out, right? So guys, the portion below that extension, I mean if I just subdivide this part, the portion below that extension, this whole thing is hindgut only, but this part of the hindgut which is present below the extension of this extension allantois, this is what you call as the cloaca. That is the cloaca. So yes, cloaca is a part of the hindgut, but that portion of the hindgut which is present below this ventral extension called as allantois, that portion is called as cloaca. We'll discuss more about this cloaca, how it divides in the upcoming part. So let's do one thing for our convenience. Let us take them in 3 parts. First, let's talk about schematically about the foregut development, then midgut and the hindgut. So guys, I'm going to start with the development of the foregut. Okay, now it's time to go a bit more schematic here. Let us say this is a gut tube. If I just draw very schematically here, this whole thing is a gut tube, which we already said is divided into foregut, midgut and hindgut. Let's say this part is foregut, here we got a midgut, and here's the hindgut. And this division of the foregut, midgut and hindgut, it is solely based on their blood supply. All these parts which are getting the direct branches from the ventral aspect, of the aorta, if this is the aorta here, and we have the 3 major branches coming from the aorta supplying this foregut, midgut and hindgut. So I'm sure you all know that foregut is supplied by this celiac trunk. Midgut supply comes from the superior mesenteric artery, and the hindgut is supplied by the inferior mesenteric artery. So that the division of the gut tube is based on the blood supply, foregut by the celiac trunk, midgut by superior mesenteric, and hindgut is by inferior mesenteric artery. We should also know that what exactly is a junction between the foregut, midgut and midgut and hindgut. I mean, what is that anatomical structure which is present at the junction of foregut and midgut and hindgut also. Now, I've seen one mistake which I've noticed people do. If you ask somebody what is the junction of the foregut and midgut, many of the people end up saying that ligament of Treves. Well, when you say ligament of Treves, you are actually thinking about the upper and the lower GI bleeding. So probably you have mixing up two things there. We are not talking about that division of the gut tube based on the ligament of Treves. That's a different thing. We are talking about the division of the foregut and midgut, and what is the junction of the foregut and midgut is the major duodenal papilla, where the bile duct is opening. On the second part of duodenum, we have major duodenal papilla. So that is the junction between the foregut and the midgut. So major duodenal papilla, that is a junction between the foregut and midgut. And between midgut and hindgut. And between midgut and hindgut, what is the junction? It is actually the junction of the right 2/3 and left 1/3 of transverse colon. The anatomical landmark here, that is the junction between the right 2/3 and left 1/3 of transverse colon. Right 2/3 and left 1/3 of transverse colon. Or you can say proximal 2/3 and distal 1/3 of transverse colon. So that's just very, very basic here, that what part is called as the foregut, what part is midgut and hindgut, what are their blood supply, and what anatomical landmark we have based on which we divide them into these three parts. So guys, let's, as I said, we are starting with the foregut here. So in the gut tube, let us focus on to the foregut part now. Let us say this tube I'm drawing right now, this is a foregut tube. So we're just looking at the foregut tube, nothing. This is foregut tube having some extensions coming out. Now all these extensions are coming from the foregut. One is the respiratory bud. One bud will be the hepatic bud, which will also have a cystic bud also in it. One will be the ventral pancreatic bud. And the one on the dorsal aspect, which is larger also, that is a dorsal pancreatic bud. Let me remind you again, this is just foregut I'm talking about. We're just looking at the foregut part. And these are extensions or these diverticulum which are coming out of the foregut tube. What diverticulums are these? This is called as the respiratory bud. That is the respiratory bud. This here is the hepatic bud. That is a hepatic bud. You can see small extension that is called a cystic bud also. That is a hepatic bud having a cystic bud as well. And then we have these pancreatic bud. This is the ventral pancreatic bud. This is ventral pancreatic bud. And this here is the dorsal pancreatic bud. Ventral and dorsal pancreatic bud. What is important to note here in the beginning itself, when you're saying these extensions are coming from the foregut, or any extension coming from the foregut or midgut or hindgut, ultimately that means the extensions are coming from the yolk sac only, isn't it? Foregut is a derivative of the yolk sac. And when you say yolk sac obviously is what? That is endodermal. That means all these buds that you're looking at right now, they're all endodermal extensions. This respiratory bud, be it hepatic, ventral, dorsal, pancreatic bud, they are all extensions of the endoderm only. They are endodermal buds. Well, no issue with the respiratory system, guys. The respiratory bud will give rise to the respiratory system. And that is why the lining epithelium of the respiratory system, lower respiratory system, it is all derived from endoderm. Well, there is no confusion in that part. So lining epithelium of respiratory system has to be endodermal because it is coming from respiratory bud. But you cannot say the same thing with that convention in the liver. Liver is derived from the hepatic bud, which makes sense. Okay, it is endodermal. But if you remember, some part of the liver was coming from the septum transversum also. Something we discussed in the general embryo. So for the liver we have to see. For the liver we have to look into these two different sources. So liver is derived from the septum transversum. That's what we said. Liver is derived from the septum transversum. Septum transversum is what? It is undifferentiated lateral plate mesoderm. So mesoderm is the thing here. So when you say septum transversum, you're thinking of mesoderm. And septum transversum was giving rise to, if you remember, to the stroma of the liver. It gives rise to the stroma of the liver. Well, not only the stroma of the liver, if you remember, it also gives rise to the Kupffer cells. Kupffer cells are also derived from where? From the septum transversum only. They are mesodermal in origin. But one derivative or one extension we are looking at here is the hepatic bud. That is the second thing. Hepatic bud, undoubtedly, that is what? That is endodermal. So whatever is derived from the hepatic bud, that will be endodermal. What hepatic bud will give rise to? Hepatic bud will give rise to the entire biliary apparatus. It will give rise to entire biliary apparatus along with obviously the cells producing bile, that is hepatocytes. Hepatocytes are not mesodermal cells. I saw this one mistake in one of the guidebook. Just be careful. Hepatocytes are not mesodermal. They are not derived from septum transversum. They are derived from the hepatic bud. They are endodermal cells. Hepatocytes are endodermal. Anything and everything related to bile. Hepatocytes, bile canaliculi, bile ductules, common bile duct, gallbladder, cystic duct. No, I mean, whatever is we have in the biliary apparatus, everything in the biliary apparatus is coming from the endoderm of the hepatic bud itself. So for the liver, be careful. Stroma of the liver. When I say stroma of the liver, I'm talking about what? Connective tissue part. So connective tissue portion of the liver and the Kupffer cells. These macrophagic Kupffer cells are derived from the mesoderm and rest is from the endoderm. Then comes the third part, that is ventral pancreatic and the dorsal pancreatic bud. Now what's the story behind this ventral and dorsal pancreatic bud, guys? For the pancreas, if I may write separately. Now let me take the part of the gut tube which is showing the pancreatic bud and nothing much. If let us say this here is the ventral pancreatic bud and this one is a dorsal pancreatic bud. Let's use some short forms only, that is VPB and this here is a DPB, ventral and dorsal pancreatic bud. These ventral and dorsal pancreatic bud, they will develop a duct system inside that is called as a ventral pancreatic duct and dorsal pancreatic duct. So this is VPD I'm writing, that is ventral pancreatic duct. And this one will be the dorsal pancreatic duct. So that is what we have with us now. We got a ventral and dorsal pancreatic bud with their duct system, that is VPD and DPD. But what you see right now, that ventral and dorsal pancreatic bud are facing opposite to each other. If this is a ventral pancreatic bud, this is dorsal pancreatic bud, they are like opposite to each other. How they going to meet with each other? Well, I'm sure that you all must have read that they say that rotation will allow the this fusion of the ventral and dorsal pancreatic bud. But rotation is slightly a misleading term, because when you think of rotation, you think of the rotation of the entire midgut loop or the foregut loop, I'm sorry. Well, imagine if the entire foregut tube will rotate, then obviously the ventral will go dorsal and dorsal will come ventral. That way they are not fusing. So what do you mean by the rotation here is, the rotation which is also called as axial rotation is the differential growth in the wall of the duodenum. There is a proliferation on one side of the wall of the duodenum and there is a reduction in the size of the other side of the duodenal wall that will bring the ventral and dorsal pancreatic bud close to each other. So the one thing which is called as axial rotation, it is not actually rotation. It is a kind of differential growth which takes place in the wall of the duodenum. So let us stick to the term which is being used for it, that is the axial rotation around the axis only, that is axial rotation, which I said it is nothing but the differential growth which takes place. And a result of this differential growth is, if you look at this ventral and dorsal pancreatic bud, they will come in close approximation, something like this. Obviously with their duct system. right? So the so-called rotation has taken place, and by the virtue of which the ventral pancreatic bud and duct, now they came in close relation. So if I may label this once again, that is ventral pancreatic bud with its duct, that is ventral pancreatic duct. This is the dorsal pancreatic bud with its duct, that is dorsal pancreatic duct. Now what happens next is, when both these ventral and dorsal pancreatic bud tissue, they fuse with each other, there is an anastomosis between the ventral pancreatic and the dorsal pancreatic duct. Within the tissue, there is a anastomosis between the ventral and the dorsal pancreatic ducts. And once this anastomosis takes place, look at the portion which I'm highlighting here, guys. This portion, the one I've highlighted, will give rise to the main pancreatic duct, also called as duct of Wilson. So guys, the main pancreatic duct, the first important derivative we're writing, that is main pancreatic duct. Main pancreatic duct, which is also called as duct of Wilson. It is derived from what? It is derived from, look at the picture, it is derived from the ventral pancreatic duct. So one is VPD, plus it is also derived from the DPD, but not entire DPD, the distal part of DPD. So it is by the VPD and then the distal part of DPD. Distal part of dorsal pancreatic duct. That is the development of the duct of Wilson. Ventral pancreatic duct plus the distal part of dorsal pancreatic duct. Whereas the remaining part, look at the portion which I am highlighting in yellow here. This remaining part will give rise to obviously what? That is accessory pancreatic duct. I mean, if you think about the gross anatomy of the pancreas, main pancreatic duct is below, and this all approximately 2 centimeter above, then we have that accessory pancreatic duct. So accessory pancreatic duct, which is also called as the duct of Santorini, also called as duct of Santorini, that is derived from the proximal part, of DPD. Distal part was contributing into the main, but the proximal part of DPD, that forms the accessory pancreatic duct or duct of Santorini. Well, this is about the duct system, that what is derived from the VPD and DPD. What about the buds? How much part of pancreas is formed by the VPB and DPB? Now you can see the ventral pancreatic bud is below. So once again, think about the gross of the pancreas, guys. When you look at the pancreas, the lower part of this ventral pancreatic bud will form the lower part. And that includes the lower portion of the head of the pancreas and also the process, that is the uncinate process we have. So derivative of the VPB, ventral pancreatic bud, will give rise to the lower head, the lower part of head, and very importantly, that is uncinate process. They target their question on this, that is uncinate process. VPB give rise to the lower head and uncinate process, whereas DPB, dorsal pancreatic bud, is the one which will give rise to the upper head, neck, body, and tail of the pancreas. I mean, remaining pancreas is by the dorsal pancreatic bud, which is larger also. So ventral pancreatic bud forms the lower head and uncinate process. Especially just remember this uncinate process, because I've seen the questions targeted on this, especially on the uncinate process part. So this is about the the development of the pancreas, the development of the duct system of the pancreas, and what the buds are forming. Now there also is one question here, that what is the most common developmental anomaly of pancreas? What is the most common developmental anomaly of pancreas? And most common developmental anomaly of pancreas, guys, is not annular pancreas, that is pancreatic divisum. Pancreatic divisum, please note that. Pancreatic divisum is the most common developmental anomaly of the pancreas. Divisum, the divided pancreas. When the ventral and dorsal pancreatic bud, let's say they're not able to fuse with each other, or even if there is a fusion of the ventral and dorsal pancreatic bud, but still there is no anastomosis between the duct system, we call it pancreatic divisum also. So this is also possible, that we have ventral pancreatic bud, the rotation has taken place, the ventral has come with the dorsal only, the buds are fused with each other, but still there is no anastomosis in the duct system. That is pancreatic divisum. The divided pancreas is all about the duct system are not anastomosing. So this is about the extensions coming from the foregut part. That is a ventral pancreatic bud and dorsal pancreatic bud, and the duct system are giving rise to. Now talking about the foregut, there is one more thing we need to look at, and that is the development of the stomach. Stomach also is a part of foregut. And before I tell you more about that what stomach related structures will give rise to, you need to again look back at the general embryology. See, we have to go back to general embryology for everything over and over again. And I'm sure if you've read the general embryology well, if you watch the videos carefully, so whatever we'll keep on discussing, that will make more sense because you know that where they're coming from. Like, if I talk about stomach, let us say this is a transverse section. The section that we, if you remember, let's say this here is the yolk sac, which is below. There is a yolk sac, that gut will be derived from it. And then we have the lateral plate mesoderm, in which the coelom is there. I'm not considering para-axial intermediate, just concentrate on this lateral plate mesoderm. And look at the coelom also there. That is intraembryonic coelom. If this is a lateral plate mesoderm and the coelom in between, this one, that is intraembryonic coelom. Just looking at that part here. Just imagine when this rotation takes place, when this whole thing will rotate. So this lateral plate mesoderm, along with its coelom, along with its intraembryonic coelom, will actually encircle the stomach. We are talking about stomach only. So it will encircle the stomach from both the sides. So you have one cavity which will be extending on the right side and one cavity extending onto the left side. So when the rotation will take place, guys, this picture will look more like this. Let us say this is the same yolk sac which is from the stomach, and these extensions will go something like this. Isn't it? So that's the lateral plate mesoderm, which is now covering the stomach. Let's say this is the stomach here. This is the lateral plate mesoderm, and that is the coelom inside. See, this also tells you one thing. This layer is in conjunction. It is adherent to the stomach, and that's why we call it what? Splanchnopleuric layer. So splanchnopleuric lateral plate mesoderm, which is adherent to the yolk sac, or you can say gut wall or stomach. So that will give rise to the visceral layer of the peritoneum. And the one which is outside, that obviously is the somatopleuric lateral plate mesoderm, and this will give rise to the parietal layer of the peritoneum. So something which we'll discuss in the peritoneum also. I'll start from this exact point to make you understand the peritoneum part. But what is the final picture we have? That we now got a stomach here, and the stomach is having this ventral mesogastrium and dorsal mesogastrium. These are the mesogastrium, guys. Look at this, isn't it? Mesogastrium. This is the ventral mesogastrium here, and that is a dorsal mesogastrium here. If I just draw it with more details here, let us say this is a stomach, and stomach part is having this ventral mesogastrium. That is a dorsal mesogastrium. Now I'm actually enlarging the cavity. Look at this, right? This is we just kind of enlarge the cavity here, and you're looking at this ventral and the dorsal mesogastrium. That one over there is a mesogastrium only. So if this is the ventral mesogastrium, there is a ventral mesogastrium, and this here is a dorsal mesogastrium. There is a ventral mesogastrium, and there is a dorsal mesogastrium. If you remember, ventral mesogastrium was contributed by the septum transversum, that ventral mesogastrium, and the dorsal mesogastrium is there behind. So whatever we discussed in the development of the liver, we said liver will develop into the ventral mesogastrium, that all that hepatic bud and everything we said, that liver develops into this ventral mesogastrium, and the spleen develops in the dorsal mesogastrium. To be more precise, spleen develops into the left layer of dorsal mesogastrium. It's more toward in the left layer of dorsal mesogastrium, if I say that. Right, so liver into the ventral mesogastrium, that all that hepatic bud we talked about, septum transversum, that is in the ventral, and the spleen, dorsal mesogastrium, which is dividing the ventral mesogastrium in two parts. Look at this. This is the ventral part of ventral mesogastrium, isn't it? And this is the dorsal part of ventral mesogastrium. This is the ventral part of dorsal mesogastrium, and there is a dorsal part of dorsal mesogastrium. And just by looking at it, this gives you an idea about that what should be the derivatives of ventral and dorsal mesogastrium, guys. Just think about it from, once again, from the gross anatomy point of view. Liver, and this is anterior abdominal wall. What is connecting the liver to anterior abdominal wall? Liver and anterior abdominal wall ligament is what? Falciform ligament. So one of the derivative of the ventral mesogastrium will be the falciform ligament. That is a falciform ligament. That is one derivative of ventral mesogastrium. Liver and stomach, they are connected by what ligament? They are connected by the lesser omentum, isn't it? That is lesser omentum, which is stretching between the liver and the stomach. And when you think of the liver is surrounded by the peritoneal, right? If we have peritoneum surrounding the liver, that peritoneal fold is not only forming the falciform ligament or lesser omentum, that is covering the liver on the top surface also, and forming other ligaments of liver which are related to the diaphragm as well. So some ligament between the liver and the diaphragm, which are facing on the upper aspect, that is the coronary ligament, which is surrounding it. That is coronary ligament. And then the tapering end of the coronary ligament called as a triangular ligament. So falciform ligament, lesser omentum, coronary ligament and triangular ligament, all these are the ligaments or extensions which are derived from ventral mesogastrium. And just to make this question sound a bit more confusing, they may not give you lesser omentum in the option. They probably might give you the two parts of lesser omentum. Lesser omentum is not only the connection between the liver and stomach, it is a connection between the liver and the first part of duodenum also. So that's why there are two parts of the lesser omentum. One is called as hepatogastric ligament and hepatoduodenal ligament. Remember these two parts separately. That is hepatogastric ligament, and we got hepatoduodenal ligament. Hepatogastric and hepatoduodenal ligament. So this makes sense. Ventral mesogastrium in front of the stomach. Now the stomach is rotated, but before the rotation, if you imagine the lesser curvature of stomach is in front, so whatever we have in front, all the ligaments or these peritoneal folds are derived from this ventral mesogastrium. Falciform ligament, coronary ligament, triangular ligament, and lesser omentum. And keeping the same principle in mind, what should be derived from dorsal mesogastrium, guys? Dorsal mesogastrium, look at this. If this is lesser omentum here, so that should be the lesser curvature of the stomach, and this opposite should be the greater curvature of the stomach. So what omentum will come from here? That is the greater omentum. So one derivative of the dorsal mesogastrium will be the greater omentum. One derivative is the greater omentum. Then let me stick to the greater curvature only. If you go along the greater curvature of stomach, now if you run along the greater curvature of stomach, you obviously will reach above where? To the fundus of stomach. And the fundus of stomach is present below the diaphragm. So the ligament connecting the fundus of stomach to the diaphragm, that is a gastrophrenic ligament. That also is a derivative of dorsal mesogastrium. That is the gastrophrenic ligament. Then you got to see stomach is connected to the spleen also. So obviously what ligament? That is gastrosplenic ligament. That is a gastrosplenic ligament. And finally, spleen is connected to the posterior abdominal wall. When spleen is connected to the level of in front of the left kidney, so that ligament from the spleen to the kidney, that is linorenal ligament. That is linorenal ligament. You call it linorenal or you can call it splenorenal ligament. That is a linorenal or splenorenal ligament. So these are all derivatives of what? Dorsal mesogastrium. So this is one very, again, popularly asked question about the derivatives of the dorsal and the ventral mesogastrium. Just think about it. Let's think about the picture before the rotation. Think about what is there in front of the stomach. That is all ventral mesogastrium, in which we have liver. Think of dorsal mesogastrium where we have spleen. And that will give you an overall idea about what will be derived from ventral and dorsal mesogastrium. So guys, this is about the foregut part. We just discussed the foregut in this, the respiratory bud, hepatic bud, ventral and dorsal pancreatic buds, and also about the stomach mesogastrium, that is dorsal and the ventral mesogastrium. In the next section, we will talk about the midgut, which is very, very important, and especially the rotation and rotational anomalies of the midgut.